Well, welcome to another episode of the Regional Hospital Voice. Today, I'm honored to have a remarkable guest, Bill Lee. Bill is the CEO of Evans Memorial Hospital in Claxton, Georgia. And so, first, I really want to thank you, Bill, for being here. It's an absolute honor and privilege to have you on the show today.
Thanks so much, Mark. I really do appreciate you asking me and look forward to our conversations.
Well, terrific. Well, before we get into anything else, what I'd really love to hear is a little more about your story, about even how you got into healthcare and the journey you took to becoming a CEO of a hospital.
Thanks again for having me on your podcast. I think about what attracted me to healthcare, and really, you know, it all goes back to as a teenager and during my formative years, my dad was very ill, and so I was around healthcare a lot and healthcare delivery in the Atlanta market, and so I was exposed to that at an early age. And while I knew I didn't want to be a clinician, I wanted to be able to impact the delivery of care because I thought it was important. And I saw all of the wait times, all of the process issues, all of the access issues that my father, who suffered from a renal failure, and back in the day when that wasn't very popular, he actually had the first kidney transplant
Hmm.
at Rady Hospital in 1976.
Wow.
And so it's funny how those things stick in your mind. And I even can tell you the name of the surgeon, Dr. Ed Macon, that performed that surgery. And at that time, I was 7 years old. And so it began there. And so throughout the next 10 to 15 years during his illness, I really felt called to be involved in healthcare. And so after I attended Oglethorpe University, I really felt like, how could I take that to the next level from a schooling and education perspective. And so further pursued my master's in health and master's in business at the dual program at Georgia State University. And so once I graduated, honestly, I have worked in healthcare ever since. And as I say at my age now, I don't think I could do anything else because I really have fit into that mold of someone who has spent a career in something that they enjoy, but also in something they have enjoyed learning about, shaping, and being a part of.
Well, I appreciate you sharing that. That is a remarkable story. But you kind of talked about having that calling. And you talked about seeing some of the issues with the impact of the delivery of care and that access. What have you seen since?
Quite frankly, it's been such an evolution. I've done this for 30 years almost now, since entering into it in the 90s. And what I have really seen is not only the accountability of the patient, which is important, but I also have seen so much that has evolved on the delivery of care and those that are actually administering it. And when I say that, the infrastructure, what's required, dealing with the payers and payer relations, really dealing with external market and headwinds, all of the things that weren't even a factor 30 years ago play into it. I think I'm old enough to where managed care was, we thought, a buzzword back when it evolved in the 90s. And one of my first roles young in my career was the director of managed care. And when the CFO came and asked me if I was willing to take that on, I thought, what in the world is that? Why would we create a role that would deal directly with contracting with payers, looking at reimbursement, looking at things that really support the infrastructure of a hospital from a revenue perspective? And, you know, fast forward to today, it is a critical role because that plays such a significant importance in our ability to have a path forward. And I say that, and I don't say that lightly because I think that without understanding that knowledge, and honestly, I think I give kudos to the CFO back in the 90s that asked me to sort of take on that challenge because throughout my career, as I have grown in positions and capacity, one of the things that I think has impressed, or I hope has impressed those that I have come to work with and for, is the fact that I have an understanding and a background in sort of payer relations, managed care, and revenue cycle. And At this point, I really hope that that's been that was a good choice.
What absolutely. And I certainly want to dive into some of the reimbursement challenges that you've seen. But I think, one of the biggest things when I talk to someone that doesn't understand healthcare, and maybe they're an excellent entrepreneurial in another industry, there's just no relation to the reimbursement of what happens in healthcare.
Absolutely. I always tell people and the board members that we have laugh and say, there's math and there's hospital math and we'll payer math. And so all of the things that people sometimes don't understand is the fact that, and I have to equate it because we have many business owners on our board and they think, well, if you can't get a loan to pay for your car or your tractor or whatever it is, or you can't pay cash, then you're not taking possession of that until that happens. Well, healthcare is not like that. Healthcare is delivered upon presentation, especially to the emergency department. And I understand that and realize that, but then we have to then figure out how do we either absorb or be reimbursed for that care that's delivered post care delivery. So it's something that you really have to think differently about. And I also say that, retail price may be retail price, but nor are we reimbursed retail price.
Yes.
So, numbers, and I know we may talk a little bit about financial transparency, which I'm a big advocate for. I think we have to be transparent in the world we live in, but I also think sometimes it's misleading. And the fact that, if people see what you charging for a certain service, but yet Medicare may reimburse you X, then unfortunately it doesn't paint a true picture of what that bottom line revenue stream looks like.
Yes, and I think that's an excellent point. I think, yeah, we may be able to spend an hour just on the transparency because there's so many fingers being pointing at hospitals saying that they need more. And we know with the No Surprises Act, and we could certainly appeal to the patient. And we know we can be ourselves a patient where we want to know what we're going to be charged and paid for. But so much of the confusion is really winding up with the payers. And they're one of the biggest advocates for that No Surprises Act because they wanted to see your numbers.
Absolutely. And I think that while again, I'm a huge advocate for patient transparency, and we talk a lot about that in many of the circles that I'm in, whether it be through ACHE or GHA or any of those that I'm involved with, while I understand it, I think there's more to the story. And I think sometimes that's what's lost in the translation. But it's up to us to educate and to make sure that our consumers know that that's where we stand and provide them with information that they can then use to the best of their knowledge and make decisions.
Well, and speaking of educating, yes, you're absolutely right. And so often the patient's confused because of some of the misinformation they're getting from the insurer. And the insurer loves pointing the finger at you for being the principal issue, even though you're the caregiver. But one of the things we have to educate is our lawmakers. And so just speaking on advocacy, I know when we were trying to schedule this episode, you mentioned that you had US Senator John Ossoff come, and I've seen on LinkedIn that you've also had US Raphael Warnock, another senator, come. And we've met at the state capitol for kind of state issues on policy. And I've seen you at least online, at the U.S. Capitol. So clearly, advocating for the hospital is so important. Kind of explain, how you address when you talk to lawmakers about some of the challenges that you're experiencing.
Well, it's ironic you brought that up. One of the biggest passions I have is advocacy. And, I think part of that has grown from the 6 years that I've been in rural healthcare. So I've celebrated most recently my sixth anniversary here at Evans Memorial as the CEO.
Oh, yeah.
Always thought, growing up in Atlanta, I always thought, I'm big city, enjoy that urban feel, work in large health hospitals and health systems. But it's really that rural voice that has really challenged me to make sure that I am involved and that I do advocate for our community and for our hospital. I always say healthy hospitals are a sign of healthy communities. And I think that's something that I share and I share over and over with those legislators and US officials. And I was very fortunate last year, 2 years ago, Senator Warnock was able to put forth an earmark that allowed us to have a roof put on our hospital. And some people say, well, that's not very sexy. And it's really not. But when you are in a rural hospital that has limited capital dollars, and the fact that a roof cost me $974,000 to re-roof this facility, coming up with $1 million for something that isn't sexy, I'm not going to have a lot of donors that want to do that. And so working with Senator Warnock's office, we were able to make that happen. And so post the installation of that, the senator contacted me and said, I want to make a visit to Claxton. I want to come see the hospital. I want to hear from you, but I want to hear from the community. So we were able to create really a town hall open session for people to come and talk with the senator, for him to tour, to see our hospital, to see what we were doing, and quite frankly, the risk of what it would look like should our hospital close, should we not have access to it. And through that opportunity, it has really allowed me to make sure that we have a seat at the table. And so you take that back down to the state level, and I have been so fortunate and that our local senators and representatives have been huge advocates and champions. And one things I've learned a long time ago is that don't call them when there's a problem. You call them continually to engage, educate them, let them know some of the challenges that are happening. They love to hear from you. They really want to have that two-way conversation. And I think it educates them, but it benefits me from hearing from their lens, what they're hearing, what they're seeing. And so one of the things that I've really learned is that continually have those conversations. And it's okay to call them when you need them to advocate for something, but don't just call them when you need them. And so I have continually had that, and that has grown in having relationships with our governor, with other people in the state that have been huge champions because at the core, they know, again, our rural hospitals are critical to long-term stability of our communities.
Yes, and I love what you said there is, healthy hospitals lead to healthy communities. And I think so often, we talk about the social safety nets, for our country. And, we obviously they talk a lot about Social Security, we talk a lot about Medicare, we talk a lot about Medicaid. I don't think we're talking about our local community hospitals enough because that's where if everything else fails, that's the only place they have to turn.
Absolutely. And I think that, as a part of our rural facilities and through the Rural Health Transformation Program that is most recently rolling out through the Big Beautiful Bill. So, regardless of your political affiliation, I think that, what is rolled out is something that we're trying to work through. But through that, there is, over 90 facilities in the state of Georgia that are designated in rural markets. And so, for the state of Georgia, all of us have independent needs, but in the aggregate, we all are thirsty to ensure that what we can provide meets the needs of our community. And that's the scariest part is retaining talent, growing workforce, meeting supply needs, all of these things that are daily challenges that we have really rests on the shoulders of many leaders across the state on how do we ensure that those hospitals are stable and relevant. And I love to use the term relevant because relevant really means that they are meeting the needs, but they're also being able to support a community and they're not the one stop shop. And they're also not the end all to be all. We know that we cannot provide every service at a high level here in Claxton, Georgia. But what I do know is that we're great to stabilize, assess, and support in a crisis or in a time of need, or for those that have immediate need, we can certainly take care of those ailments and illnesses, but also that we have relationships with larger tertiary centers that they rely on us and we rely on them to be able to support and connect healthcare from a rural to a more urban setting.
Wow, that's excellent. And I definitely want to hit on that rural health transformation, what you're seeing there. But one thing you hit upon that I'm hearing quite a bit, we're talking about the shortage of clinicians in this country is being felt in every state. But we know it hits rural areas the hardest. And particularly, a lot of the residency programs are not in rural areas, and a lot of the schools are not in rural areas. So they typically stay where they come out of school, which is understandable, as much time and as debt that they have as they come out. How is the workforce shortage kind of showing up for you? And, has it forced you to be creative about anything?
Absolutely, and that's a great question. And we look at it that we have to continue to build a pipeline. The best way to build a pipeline is to work directly with the source. And when I say source, the medical school, the institution, we have great medical schools in the state of Georgia. And quite frankly, I'm blessed in South Georgia that we have representation from almost all of our medical schools. And saying that we have recently become a medical student rural rotation site. So we work with MCG, we work with Mercer, and other medical schools so that many of the medical students experience the opportunity to come to Claxton, come to Evans Memorial, work with our hospitalists, work with our surgeons, work with our emergency providers, and get the firsthand look at what does it feel like to deliver care in a rural market, in a rural hospital. Many of those are themselves from rural areas. And obviously, that's a big goal Mercer has is to accept 100% from the state of Georgia. Many of their students are from the rural markets. And so it's not that they haven't lived it, breathed it, and observed it, but to actually work in an environment where you are the sole provider or sole hospital in a community is important. And I think that as we think about that, we try to really impress upon them what you can get by serving a community in a rural market. And so that has been a wonderful opportunity for us. And so over the last few years, we've been able to grow that and work directly with those medical schools and institutions. And honestly, we've had some opportunities to I've recruited a general surgeon who was a fellow at Memorial in Savannah. He was actually the chief resident and then did the fellowship there in general surgery. And so we recruited him here about 2 years ago, and it was exciting for me to bring someone who, even though they were in a little larger market in Savannah, they had an affinity to be in a rural market and have enjoyed, getting to know their patients and their community, and it's just a different feel. And so for a young person who's growing their family to commit to being in a rural market, I feel very blessed and very fortunate in that scenario. And we've continued to try to do that. And if you take it down to, staff and nursing and other levels, that we alluded to with workforce development. We again partner with Ogeechee Technical College, with Georgia Southern University, with Coastal Pines, with a lot of other nursing schools that really we can feed our program and allow people to experience it and to feel like this is somewhere I really want to practice. I want to be able to be hands on and you're diverse. You get the sickest of the sick and then you get those that are here for more routine care. And so I think that's what's important is it really shows the diversity of what we can provide. So again, partnering with the source is what I call it. And so I have been fortunate to be able to bridge and build those relationships and our team to build those relationships in those capacities.
Well, excellent. And, we just kind of talked about one, you're being an advocate. We talked about you just now being a recruiter, if you will. And, you're still having to run a hospital on the side of all this. So I think you have the hardest job in healthcare. I mean, what is something that, a lot of people may not understand about the other challenges of running a rural hospital?
Well, I think you'd always laugh and say, well, I have your day job and then I have my side gig. And the side gig is, hospital operations. And so, I think that is something that people don't quite understand. And they don't know that from our perspective, we have to be front and center with all levels in the organization, from our physician partners all the way down to our, board members, to our community leaders, to our staff that I call support staff that are integral into the continuum of care. I am someone who started my career in patient access at Piedmont Hospital
Oh,
in
wow.
1992. So my love and affinity for someone who works in patient access is so big. And so in orientation, when we have monthly orientation, and I welcome our new employees, I always look to those that work in patient access and say, you know, I relate. I can really resemble what you're doing. And I find it so important. And I think people lose sight of how do you take someone who is, someone who comes in and is really the front line of of advocating for your hospital, representing for your hospital. They're the ambassador. And so I really think that working, to support teams at that level who are really sending the message, and then, at the end of the day, worrying about the fact that our revenue cycle is operating okay because, you know, as they say, no ticket, no ride. If you have no cash, you can't make payroll. And as a rural hospital CEO, that is the heaviest burden that you can have, is that you have 250 people that work here every day who give tirelessly 365, 24/7. And so I really feel like that as a rural hospital leader, and all of my colleagues would say, I mean, I have spoken with colleagues that said they have prayed at night that they can make payroll that week. And that is a scary feeling. And it's not foreign for a lot of people. And when you read about rural hospital closures across the state, across the country, it's real. And so though we're out advocating and we're recruiting and we're making sure that we've got pipelines and that we make sure that we can talk to senators, all of that matters immensely. But at the core, what matters is that you understand how do you control your spend, your revenue cycle, your cash flow. And unfortunately, you're in a business that you can't always predict. Sure, you've got all of these things that you can look and project numbers and data because you have to be able to look historically. But that doesn't mean that in July, if everybody's on vacation and your volume dips, how do you flex? How do you control your expenditures? My supply costs don't change from what I need to do. I just maybe order less, but you still cost the same. So all of these things factor into the equation that we have to think about. And that honestly is the scariest part of my job is how you balance that day in and day out and, plan for emergencies when sometimes there's not funding to have an emergency. I always say you're about one pay period away from a disaster.
Well, and you really hit on a lot. And I love what you said. How do you balance and plan? And too often, especially when I talk to lawmakers, we're saying, well, what are some of the reasons, which you've hit on a tremendous amount already in this episode about the challenges that rural hospital faces. But one of which is it's not necessarily lack of patients, it's that the patients have the wrong payer mix. And you can't
Absolutely.
control the payer mix that comes into that hospital, and it's your experience in the managed care and in the rev cycle. What are some of the biggest things that you try to control as it pertains to that payer mix and some of those reimbursement challenges?
Well, obviously, we have to be careful because we are a public rural facility and we are subject to every governance and policy with regards to EMTALA and every thing that governs our need to see patients and assess and triage patients. But at the end of the day, we really try to do things internally where we have had our team trained and certified through the state to do presumptive eligibility for those that have either lost coverage or seeking coverage, could qualify for some level of coverage. We have done that as part of our team, but again, that's a cost that we have to bear, but it's an important service that we're providing. And so I think that's something that we have done in order to try to manage the self-pay, if you will, because at the end of the day, self-pay is something that we manage every month, meaning that we try to make sure that we're balancing. We have historically run about 10% self-pay across our entire portfolio, which quite frankly, as a rural hospital, I feel positive about that. But if you extrapolate out the emergency room visits, it's more around 35 or 40%. And so those are those that are converting that are truly through our system. In the aggregate would be about 10%. And so we really try to hit that mark. We've gotten as high as 13 while I've been here, and we've been as low as 8. And so, but on average, say 10. But those are the things that we do. So we try to make sure that we are, with financial counselors, with social services, we're really working with those patients to see if there is any opportunity. But quite frankly, when we are, with Medicaid redetermination, post-COVID, a lot of the factors that have gone to it, and honestly, with certain, accountability amongst individuals, if people don't apply or follow through with the process, then we can only do so much to provide them coverage.
Yeah, I think and that's another great point is we often hear, hospitals aren't trying. Well, it's not that we also need help from the patient. And so they're definitely
That's
more than trying. And I think that's also lost in the conversation.
It's a partnership, and I think that's something that we have to do. We try to tell, our patients that we want to partner and support you in any way we can. That's why we've got people that'll do one-to-one on counseling, financial counseling, but at the end of the day, they have to participate in the process.
Yes. And you at the beginning you talked about needing a roof because it's not cheap to run a facility such as yours. And not to mention it's aging. How
Right.
old is the facility?
We will soon be 60 years old.
60 years old.
So we were built out of a vision in 1968, and so we're small but mighty, is what we say. 60 years going.
Fantastic. Well, and so you talk about the expense of the facility. We talked about kind of the expense of one, you're needing personnel that you probably didn't need 20 something years ago, especially for prior authorizations, also for these signing for the eligibility. And, too often there's like, well, there's too much admin in the hospitals. But then we also hear that you actually have more regulation. I think I heard on a podcast episode, the last one, Aaron says you have more regulation than nuclear energy.
And so I think that is part of it, is that with the regulations that are out, but with compliance, we have to make sure we are very focused and prescriptive with regards to compliance. And we take that seriously here, but it takes people to be compliant, because you have to check and balance so many things that are required. So whether it be through our D&B accreditation, through CMS, through all of these different organizations that you are a part of and receive federal funding for, we have to make sure that we do that. And it takes more people to do that. But to your point, we are a 60-year-old facility. And it's much like a human that's 60 years old. I'm getting closer to that, so I can say that. But as a human at 60, it takes more maintenance. It takes sometimes more replacement parts. And so when we have chillers and air conditioner systems that are now, second generation, 30 years old, so they've been replaced once. Now that we're in a need for another, I could easily spend 500 to $750,000 in replacing all three chillers in this hospital. And
Wow.
so those are the kinds of things that are no fun to do. You have an air conditioner or humidity chiller go out in the OR. You have to close down your operating room. You have lost revenue. You're not in compliance with the specs in order from an infectious disease, infection control perspective. All of those things focus on making it hard to run a business when you don't have the most modern, upgraded technical equipment and monitoring for that. And so those are the things that we're forced to have. And so we have, again, you talked about aging roofs, we've got aging infrastructure that costs money. And so those are the things that we are all challenged with on how do you essentially rob Peter to pay Paul. I've looked back and it takes about roughly between 57 and $60,000 a day to run this facility.
Wow.
So that is, lights on, supplies, staff, all of those things that you can think about. And quite frankly, that's really below the benchmark. So we felt good to keep it at that. So around 57 to $60,000 a day. So when you think about that, while that doesn't seem like a large number to a lot of big hospitals or urban facilities, it's a large number here. And so you have to balance that with the revenue stream. So when we think about what we're getting with the uptick in Medicare Advantage, so when I started here 6 years ago, 19% of our payer mix was Medicare Advantage. At the end of June, when we closed the books, it was 31%.
Wow.
So you think about a population that is often very hard to manage with regards to pre-cert, pre-auth, um, uh, following sort of the rules of looking at authorizations and the timeline for that, and sometimes a sicker population with a lot of comorbidities who need things more urgently. We are facing more and more denials, denials for inpatient stay for criteria, denials for CTs, MRIs, denials for things that historically through traditional Medicare, we were not facing that same level of scrutiny. And I use the word scrutiny, meaning we must use our resources correctly, but we also have to have more resources in order to deal with the rules, the regs, and all of those things that are put forth in those Medicare Advantage plans. And so while I am an advocate for choice and people should have choice in their health plan, it's also critical for people that are in, you know, elected official capacities, other people, decision makers, lawmakers to understand that there is a burden that is then placed on the delivery of care with regards to us and what we have to do. And so when you take 19% and go to 31%, in the average days of collection for Medicare, we usually get paid within 14 to 16 days, depending upon the billing cycle. It's around 56 to 65. And that is if we don't have to appeal or rebuild something because they found an error in the way the file was sent over. And so when you talk about the delay of cash, you talk about payroll, you talk about expense, you talk about broken and aged facilities. All of those things create a perfect storm in which, as leadership in rural hospitals, we struggle because we struggle to find a balance on how you juggle all that. It's truly a juggling act. I feel like some days not only do we run a circus, but we're involved with the ringleader and with the juggling act because you have to balance all of that. And so those are the kinds of things that over the course of my 30 years in doing this have become more complex, more complicated, and quite frankly, it makes you scratch your head and say, how much more can systems endure or hospitals endure with regards to being able to just simply ensure relevance and ensure people can access the care they need in the community?
Yes, and I think so often, when I talk to lawmakers, they want to prevent hospitals from joining large systems. But it seems like the regulation they continue to put out is just fueling that mergers and acquisition. So, kind of tell me, if there was one change, a rule, a payment model, or anything, what really help hospitals like yours continue to serve excellent right now, but continue to be relevant in the community?
Well, I'll say one thing, we can always be better. And so I know that. And I come to work every day knowing myself personally can be better and what we deliver can be better. And what that looks like is, there's a lot of people that don't seek certain care because they don't have those subspecialists local and they don't have transportation. Transportation is a key issue in rural healthcare, getting to follow-up appointments, getting to specialist appointments. And so a lot of people, when they're discharged from here and they need to see a cardiologist, an endocrinologist, a gastroenterologist, one of the specialists that may not be readily available in Claxton, and they don't have transportation to go to travel to go do that, then they just don't go. And so therefore, the cost of care when they show up with another episodic event or if something happens and the long-term cost of care for those individuals is higher and higher. And so all of those factors have to be created. And I can't be responsible for transportation for all of the patients that present at Evans Memorial. But I can tell you, because of the shift and the scarcity of EMS resources, the scarcity of uh, transportation through Medicaid providers, through the state funded agency, through MODIO, all of those things are something that we've had to then take patients home. We have to
Wow.
provide transportation to get them out of the bed because their care is no longer being covered. by the payer. They told us they needed to be discharged, but yet they had no way to get home and or they had no home environment that could essentially support them in that means. And so we have really had to take a front seat in that process. And so I would say on a weekly basis, we have to advocate for transportation for over 20% of our patients. And so those are the kinds of things that I think are sometimes overlooked. And then when you funnel in the uninsured, the underinsured, our uninsured grew several $1 million last year. And we have faced, difficult challenges and try to blend that and balance that. And quite honestly, we haven't seen a big increase in payment from payers or from other vehicles of that. And so we rely heavily upon philanthropy.
Mm.
And so, I advocate that to our lawmakers. And so one of the things that we've appreciated what they've done, and as I sit here on my desk, I look and I'm very fond and there I'm in the biggest fan club for, the Georgia Heart program here that our legislators have been instrumental in raising the cap to $100 million for those that across the state for those that want to contribute as our statewide cap from 75 million. That is a great start because it's getting the message out there that we rely heavily on that. I would be the first to say we would not have a positive bottom line if we did not have philanthropy and
Wow.
stewardship. And so those are the kinds of things. So when you add to the plate, so now I've become the foundation president and the philanthropist and the fundraiser. And I always tell people in orientation, and I say, please repeat after me. We are all fundraisers because at the end of the day, everyone that you encounter, everyone that you treat, everyone that you see could potentially be a fundraiser and supporter through either the Georgia Heart, through our foundation program. Last year, we raised 1.6 million through Georgia Heart.
Oh, incredible.
I am grateful for the work that they do, the message that they send, the advocacy that they do on our behalf, because we, again, without them, would be in a different situation. And honestly, I think there's a lot of our facilities. I can only speak for myself, but I hear enough from my colleagues to know we would all be in a different situation did we not have the support through the Georgia Heart Program and through a philanthropic giving.
Well, yeah, and thank goodness for that support. And I think that just leads into, a broader question is it's clear the reimbursement model is not working. If you're having to rely on earmarks for roofs, you're having to rely on this philanthropy. So what do you see that needs to happen to really ease that burden for our rural hospitals?
Well, and I'm cautiously optimistic as we roll out. We referenced earlier the Rural Health Transformation Program, and part of this program in the state of Georgia is the Great Health Program and the AHEAD model, which is a model in which they're working to define and roll out with the help of CMS approval with our friends and colleagues at DCH with GHA and others are really looking at how can we make that attainable and feasible for our rural facilities. And so I think that I am cautiously optimistic, back to my original point in your question, that we are going to get to a point where we have a different reimbursement model that will then support us being a sort of a captive audience in a community that's serving regardless of ability to pay. And so we have to make sure that whether it be through Medicare, Medicare Advantage, Medicaid, the uninsured, or a commercial payer, that we have a blend that can support us operationally. And we are not out to make a profit. We are obviously a not for profit organization, but no margin, no mission. And our mission is driven on being able to have funding that will secure our long-term sustainability and survivability. And so at the end of the day, I think we have to relook at the platform in which we're reimbursed in rural markets. And again, I'm not saying we're the same as a Grady or others that have a very high population in an urban setting, but I do know that when you look at what it costs me to employ a tech or a nurse or a physician, it is not that disparate between the state, whether I'm in Macon or Savannah or Claxton. And so those are the kinds of things that I think we have to be able to push upon, um, regardless of the fact that we may be in a rural zip code. We still have a price tag that the cost of delivering care has increased insurmountable post COVID. And so when you look at what that looked like, pre 20 to where it is 6 years later, it is nowhere the same. And that's whether it be supplies, workforce, people, which our human capital is our big investment.
Mhm.
65 to 70% of our revenue goes to our human capital, which in any organization it really should, because you have to invest in your people. But it's hard to do that when you don't feel like reimbursements are really shrinking. And I'll use that word. They're shrinking. The payer mix shift has driven a lot of that. And so how do we find balance? And, honestly, I wish I knew a very direct answer, but I don't. And if I did, they would hire me. They do something much bigger than this, but I really don't know. But I do know that what we live and do every day is reliant upon that. And it's become much more of a challenge.
Well, and I think, you're definitely with all the advocacy you're doing, it's certainly, we've got to get the word out. So let me ask you, for community members that might be listening, who want to support with our community rural hospital, what should they know or do?
Well, first of all, I think it's important, and everybody can support, or everybody can, but won't, but everybody could if they choose to support philanthropically. But what's more important to me is support around advocating to use and utilize your rural hospital for, you know, daily needs, for your daily care, for routine, for your mammogram, for your endoscopies, for your scopes. Don't travel 50, 60 miles out to the larger center and bypass your rural hospital and think I'm only going to use them if I'm having a heart attack or a
Mhm.
stroke. That's great. That's what we're here for, obviously. But what we rely upon is for those to use us for routine. And when we don't get used for routine, it's very difficult. And therefore, the first message I have is that we have to have confidence. And what I feel like we have built over 6 years, we're neighbors caring for neighbors here. You have to have confidence in what we're doing here locally. We know these patients more than anything. We want the best outcomes for these patients. We are getting highly skilled and trained caregivers to work here. So please trust us to come and seek your care. That is first and foremost. And I feel like over the last few years, we have built a huge community support. We sent out a rallying cry 6 years ago when we were on the list of likely to most close in our community. In fact, close to a vote by the commissioners to close the facility. Hence, COVID came, unintended consequence. Yes, we got funding, but that wasn't necessarily funding to create a long-term savings account. It was funding to be able to support the needs that were current and front. And quite frankly, we were subject to many audits to make sure that that's what we did. And so glad to say that we have had no issue with that. But at the end of the day, many people feel like, well, I think when you received money during COVID, why did you just save that money? Well, if you saved it, you had to pay it back because we weren't supposed to be Evans Memorial National Bank. We were supposed to be providing care delivery and using those monies to ensure that we had equipment, supplies, and staff to do so. And that's what we did. And so fast forward, we've continued to grow our volumes. We've grown our volumes by 25 to 30%. If the board would say that's not enough, and they're saying that as a negative, they're saying that unfortunately in the world we live in and the economics in which we live in and the way we do hospital math, it doesn't add up. So you
Yeah.
grow your services. So we have to then rely on those donors and donors even through our foundation. or donors through tax credit. So if you have tax liability with the state of Georgia and you have to pay that anyway, please redirect that. So, if you have a liability, it makes sense that it should go to something that could be beneficial in our community. And so we've really reached out to try to make sure that we have done that. And we are grateful for those that recognize that and see that. Last year we had over 55 people, corporations and individuals, donate through our individual Georgia Heart Tax Credit Program here at Evans Memorial. And so I'm grateful for those 55. And so this year we're trying to make it 75 and make sure that number can get larger. Our goal this year is 2 million. And so we were again 1.6 last year. And so we've got a lot of push on that. We're halfway through the year and we've hit a million. So I think it's feasible. We keep pushing. But again, that's yet another task that we as our facility leadership team is tasked with, is how do we continue to engage and promote that? But quite frankly, quality is our focus and our patient is always at the center. And I think all of those things come with, if we show quality, if we show our outcomes are positive, then people will have confidence, they will support you, and therefore comes your revenue and your, you know, giving.
Well, I really like that, and especially neighbors caring for neighbors. I think that says it all. That's unbelievable. Let me ask, someone that's stepping into your role tomorrow, and maybe you could go back and talk to yourself 20 years ago, someone that's coming in as a new CEO of a rural hospital, what would you tell them?
Have faith, because if you don't have faith, you're not going to make it. But in all seriousness, I tell them that they have to be able to multitask, because if you can't multitask, then you are not going to be successful. You have many things that are compelling cases to take your attention. And I think that you have to be able to balance that and do that. And the most important thing I think that I would tell someone is they have to be visible and they have to always be willing to listen to their staff, their team. We don't call them staff here, they're team members. Those team members they are our everything here. And so I feel so lucky and fortunate to have the team we have. And I tell them that part of my day is I round in the morning and I round before I leave every day. Obviously, if I'm out of town or on work business, I'm not here. But if I am here, I always round. And it's not just about rounding to say, I'm here. It's rounding to say, how are you? How are things going down here? Do you have what you need? I know sometimes we struggle with having the latest in technology. I know that sometimes we don't have the best computer systems or the best EHR or that we have the most latest and greatest devices. But what do we have? And are you able to fulfill your job? And then more importantly, I want to know, how's your mom? How's your dad, your kids, everyone well? Because there is not one person, even when we have visitors here, when the senator was here and I rounded, he says, wow, you know these people. And I know these people in a small hospital. I know when someone who is here and not in a place they need to be or wandering a hall, I'm always like, who is that? What are they doing here? And you have to be on it. But part of that is you have to be engaging to your team. And again, I am certainly not perfect, no way, shape, or form. But what I do say is that I care and I want to make sure that my team knows that I care. And so, from that perspective, that is what I would tell someone who is crazy enough to enter into this career, if they're young and healthy. And
That's
I
really
always tell people
powerful.
there's a reason I'm bald, and it's not because of my children.
Well, I will say that's really powerful, and especially, it's clear that you care, not only for your team, but you care for rural hospitals, you care for your community, and so that certainly comes out.
Well, no doubt. And, and I care about engaging with wonderful people like yourself who are trying to get our message out, because this is what it takes. And it takes all of us. And I am fortunate I have spent the last 5.5 years on the board for the Georgia Hospital Association as a trustee. And it has been a wonderful experience because I am filled with joy when I'm around all of my colleagues that are advocating for like-mindedness. And nothing can describe that feeling, and I know that sounds sorta quirky and odd, but it's when you're together and you feel like you're all advocating for something that's so important that can't be lost in translation, and unfortunately, that so many people that you've hit on don't understand. They don't get it, they don't understand it, and right frankly, they don't want to. They just wanna make sure you're there. And so I'm always excited to be a part of something big, and it really advocating for healthcare is that thing.
I couldn't agree with you more, and I really loved everything you just said there. And in the end, it's all about protecting access. It's protecting our communities, and it begins by protecting our rural hospitals.
Absolutely. I also have to be, you know, politically correct sometimes because, and that's one thing and I will just add to you to say that, often, we have to at some level in my role, the board teased me one day and they said, "Are you ever gonna run for political office?" And I said, "I hope not." And they said, "Well, you have to you can act like a politician." I says, "Well, we are politicians because I can't have allegiance to just one. I have to cross party lines. I have to look at all of the things because at the end of the day, when I am voting, when I am advocating for Evans Memorial. And that is what's important. And so they have to know that whether you're a Republican or a Democrat or where you sit or an independent in this big food chain of America, that if we can be benefited by your decision making and educating you, that's what we have to do. And so it has been a learning experience for me because sometimes I want to say what I think and I do, but I have to be more constructive. So
Well, and I really appreciate you sharing that. Yeah, and I would just add, too often it's all about where can we find common ground
Mhm.
and access to care. If that's not common ground, then I don't think you're part of the conversation.
I always often think, and as I am about to have a birthday tomorrow, so circle the year one more time, I always reflect and I always think, what would I do different? I'm blessed. I have a wonderful wife and children, and they're adulting now, which I'm grateful for. But when I look at my career, I would change nothing. I had the opportunity to work in a large pediatric health system at Children's Healthcare of Atlanta and become a certified pediatric snob, which I am around pediatric care delivery, and then work at Memorial, really in Savannah, in a urban population, but serving such a great low country community, and then here to end up in a rural market as a CEO, I would have told you you were crazy that I would never agree to do something like that. But I have no regrets because it's it's been a wonderful career and I've enjoyed it. And I really think that I can't wait to continue to impact and see what we can do in the next chapter of healthcare, whatever's written.
Well, you absolutely should not have any regrets, and it's just a remarkable story, and I just can't thank you enough for coming on this episode, and more importantly, I hope you have a tremendous birthday tomorrow.
Well, thank you. I am sure I will. And I appreciate your time. And I appreciate the fact that you care and that you care to make sure that our message is sent.
Absolutely. Well, thank you so much, Bill.
Thank you so much. It's been great.